So welcome to day 2 of EULAR 2021, the EULAR news. So we're sitting here virtually, but feeling almost like being in Paris. So my name is Tue Wenzel-Kraustrup. I'm an associate professor in immunopharmacology at the Department of Biomedicine at Aarhus University. I'm also an MD and currently training in rheumatology, currently at the Department of Rheumatology at Aarhus University Hospital in Denmark. And I'm here with my co-host, Dr. Mrinalini Day. So happy to see you.
Great to see you as well for another day of Congress. Yes, my name's Mrinalini Day. I'm an academic clinical fellow and rheumatology registrar training in Liverpool in the UK. And today featured many fantastic sessions, some of which I'm looking forward to watching later, which I guess is the beauty of a virtual Congress. So Tue, what were your highlights from today?
Yeah, exactly. So there were so many great talks today. Just to select a few has been extremely difficult. My part of the report focuses on rheumatic immune-related adverse events with immune checkpoint inhibitors. But it was also impossible for me not to also highlight the session with one of my favorite topics, which is bedside to bench translation of clinical studies.
Great. And a bit later in the program, I'll be presenting my highlights from the What is New session on giant cell arteritis, which I found really helpful from a clinical perspective, and also discussing one of my favorite topics, which is infection risk and vaccination. One of the beauties of rheumatology is the crossover with other specialties and the many different people we get to work with. And Tue is going to tell us more about some talks he attended today on the intersection between oncology and rheumatology.
Yeah, so in fact, today there were 2 sessions dedicated to this intersection of oncology and rheumatology. The first one was oncorheumatology, the crossroads of cancer and musculoskeletal diseases. And the other one was immune events with checkpoint inhibitors. So the first presentation I want to highlight is titled Immune-related adverse events of immune checkpoint inhibitors, the EULAR points to consider. And this was presented by Dr. Marie Costin. So the last decade has really revolutionized oncology with the emergence of these immune checkpoint inhibitors. However, these exponentially growing treatments have created like an epidemic of completely new side effects. And these are called immune-related adverse events. So during cancer treatment with immune checkpoint inhibitors, it is believed that, for instance, 2 to 4% of patients develop inflammatory arthritis. This adverse event sort of resembles traditional immune-mediated inflammatory arthritis. However, the underlying immunological mechanisms of the immune checkpoint inhibitor associated inflammatory arthritis are really poorly understood, and we have almost no data to guide management.
So it's really great that EULAR are here to help with some points to consider.
Yes, so indeed, yeah. So the first talk I want to highlight is Dr. Marie Costin presenting the EULAR points to consider for immune-related adverse events of immune checkpoint inhibitors. So she gave many overarching principles and general points to consider that are very useful for setting up collaboration with oncologists at your local department. The task force also highlights some points to consider for treatment, which is probably the most difficult part. So the task force, for instance, points out that when a DMARD is necessary for immune checkpoint inhibitor-induced arthritis, then methotrexate could be first line. And if a biological DMARD is needed, the recommendation was to choose either a TNF inhibitor or an IL-6 receptor inhibitor. But an important part of the EULAR points to consider was also the list of future research topics. And this list was very, very long.
Yes, and following on from that, there have been some interesting abstracts on this topic presented today. Did you manage to catch any of them?
Yeah, so because this is such a new topic, it was really good to see abstracts with new data in this research field. I want to highlight 3 studies, in fact. So the first is our presentation 0186, and this was titled Changes in Circulating B cell levels and Immunophenotype are associated with development of arthritis following treatment with checkpoint inhibitors. And this was presented by Dr. Marielle Gatto. So anti-cancer effect of immunotherapy with checkpoint inhibitors is believed to be sort of mediated primarily by the CD8 positive T cells. So these cytotoxic T cells are definitely activated, but it is not really known what happens to other cells. And this study looks at B cells. So the study is rather small, included 6 patients with checkpoint inhibitor-induced arthritis, and then 7 patients on the same immunotherapy, but not developing arthritis. And by flow cytometry, these researchers found a significant increase of circulating B cells, and especially of transitional B cells, in checkpoint inhibitor-induced arthritis versus patients not developing arthritis.
So what does this mean for now and in the future?
Yeah, so this study is obviously basic science, but it is fundamental to understand what is going on to improve treatment. And especially because we have very efficient targeted therapies, including B-cell depleting drugs. So I will mention that we will likely also learn a lot about B-cells and immune-related adverse events from hematologists in the future, because now hematologists have started combining immune checkpoint inhibitors together with B-cell depletion to treat their B-cell hematologic malignancies. So we will see how this changes the adverse event profiles in the future.
Great. And there was also some clinical abstracts in this area as well, weren't there?
Yes. So in a clinical study, Dr. David Liu looked at PMR and GCA changes on PET scans in asymptomatic patients receiving immune checkpoint inhibitor therapy. And this is our presentation 0194. So the hypothesis here was that sort of low-grade subclinical PMR, GCA-related changes on PET-CT would be present if immune checkpoint inhibitor therapy induces sort of a spectrum of generalized immune activation. So this was a very smart study because the PET scans were already performed as part of oncological staging purposes, but was then re-evaluated for PMR and GCA changes. So 24 patients were assessed and no significant difference in PET signal was noted at any PMR or GCA relevant anatomical sites. So this sort of supports the proposition that immunotherapy does not cause this sort of generalized immune activation with PMR-like changes on PET-CT, rather PMR or GCA in relation to immune checkpoint inhibitor treatment should be rather considered as a distinctive disease manifestation.
Great. And did you find any interesting posters on this topic as well?
Yeah, so I saw a very interesting poster also. This was Dr. Diekman presented, poster 0293. This was reporting on a register-based study with real-world data following patients with inflammatory arthritis induced by immune checkpoint inhibitor therapy. So they included 64 patients due to development of arthritis under immune checkpoint inhibitor treatment, and the follow-up time was up to 30 months. So the first very interesting observation was that immune checkpoint inhibitor-induced arthritis actually mostly resembled phenotypes of spondyloarthritis, of SPA. So almost none of the patients had positive autoantibodies, while almost all of the patients had signs of inflammation on ultrasound and also elevated CRP levels. And the second interesting observation in this study was that the rate of developing immune checkpoint inhibitor-induced arthritis was actually differing according to cancer type. So 13% of melanoma patients developed immune checkpoint inhibitor-induced arthritis, while this number was only 4% in the non-small cell lung cancer patients. So now from immune checkpoint inhibitors to infections, Renalini.
Yes, so due to the events of the last 18 months, the risk of infection posed by both the diseases and immunosuppressive drugs used in the treatment of rheumatic diseases has really been brought into sharp focus. The past year has also seen the introduction of new medications which carry their own infection risks. One of these, which has been highlighted today, is filgotinib, a JAK inhibitor, which has been approved for use in Europe for rheumatoid arthritis. So oral abstract 0126 on infections and serious infections in filgotinib in the non-biologic and small molecule abstract session, presented results from the Gottinib rheumatoid arthritis program. So this abstract demonstrated results which showed that out of 2,267 patients treated with 200 milligrams of filgotinib and 1,647 patients treated with 100 milligrams, 1,697 in total had treatment emergent infection, 118 of which were serious infections. Now, like a lot of the biologic and targeted synthetic drugs that we use, the most common infections found were upper respiratory tract infection and nasopharyngitis, and actually pneumonia was the most common serious infection. So all in all, the results showed that exposure-adjusted incidence rates of infections and serious infections for filgotinib were in fact similar to placebo, adalimumab, and methotrexate. And at 52 weeks, serious infection incidence rates were comparable for both 100 milligrams and 200 milligrams of filgotinib, and long-term serious infection incidence rates for 100 milligrams filgotinib was slightly higher than for 200 milligrams.
Thank you. And did you see any other presentations on infection today?
Yes, there was lots on infection and vaccinations throughout today's program, which was great if you've got an interest in this area. And so today also featured an excellent case-based discussion session on vaccinations for immunosuppressed rheumatological patients. Very relevant, of course, for current times, whilst the COVID vaccination program is being rolled out across Europe. The case is focused on the adjustment of immunosuppression in patients with rheumatoid arthritis undergoing surgery, followed by a case on vaccinations for patients with rheumatoid arthritis, especially in the context of travel. So I found this session particularly helpful as neither scenario is that uncommon in clinical practice, and the cases raised important questions and points for discussion. So definitely one to catch up on if you missed it. So Tu, what other sessions did you attend today?
So my other report for today is from the bedside to bench session. So the title of the session is From Bedside to Bench, Unexpected Results of Clinical Studies that Change Our Understanding of the Disease. So the whole session was just absolutely fantastic. So the basis for this concept is that clinical trials with immunosuppressive drugs can help either confirm or disprove in vitro and animal model findings. So in other words, the clinical efficacy or lack of efficacy of drugs with well-characterized immunological targets will generate imperative reverse translation or bedside to bench information about immune pathogenesis. So I will just highlight one of the presentations. This was the SPA talk performed by Professor Desiree van der Heijden. So Professor van der Heijden starts out by showing just all the key cytokine pathways where we have targeted drugs that have been tested. And then she just goes through all the clinical data proving or disproving the relevance of these different pathways. So some of the data will be well known to many rheumatologists, but we were also enlightened with very exciting studies on abatacept, IL-1 inhibition, IL-6 receptor inhibition, and B-cell depletion. And further, she, in the end, also showed how the surprising lack of effect of IL-23 inhibitors in axial SPA will sort of require refinements of the classical understanding of the IL-23-Th17 axis. So Mrinalini, for our last highlight for today, you went to the What is New session on GCA.
Yes, absolutely. So this afternoon we had a What is New session, which are interspersed throughout the EULAR program. And this particular one was led by Dr. Sarah Mackey on giant cell arteritis. And I really enjoyed the session, especially as a trainee who regularly is asked to assess patients with potential diagnoses of GCA. So the background to this is that last year, the publication of some key guidelines has taken place in this area, including the British Society for Rheumatology guideline in the Rheumatology Journal, as well as the 2018 update of the EULAR recommendations for the management of large vessel vasculitis. And there's also an ACR Vasculitis Foundation guideline currently under preparation as well.
Okay, so what were your particular highlights from this interesting session?
Yes, so there was many highlights. So Dr. Mackey told us the importance of asking, for example, about family history in patients with suspected GCA, and the fact that GCA can present with unilateral limb symptoms, as well as looking out for false positive halo signs on vascular ultrasound, and also to be aware that the halo in the vertebral artery may herald stroke in GCA patients. So some really important clinical points to consider there. And then with regards to the visual symptoms, we were reminded that ocular involvement may be revealed by MRI or OCT, and that patients with double vision should be sent without delay to ophthalmology. And this is due to the check mark sign, which is enhancement of the cranial nerve 3 on high resolution 3D contrast enhanced 3T MRI. In addition to that, in terms of ophthalmological signs to look out for, diplopia, as I've just mentioned, at presentation of GCA will often have ocular ischemia, which is rescuable, especially when you compare it to other visual symptoms such as amaurosis fugax and frank visual loss. It was a highly informative session with some really relevant points for clinical practice. So I'd really encourage everyone to catch up on that if you weren't able to watch it today.
Well, these were the reports from day 2 of EULAR News. Tomorrow, I look forward to seeing talks about new drugs in psoriatic arthritis, and also very much to hear an expert interpretation of the oral surveillance study. What about you, Mrinalini?
Yes, so tomorrow is going to be another busy day. I'm hoping to attend the difficult to treat rheumatoid arthritis session, as well as watch some oral presentations in the epidemiology and COVID categories.
Okay, everybody. Thank you very much for tuning in, and I'll see you tomorrow.
Thanks, bye.